Hey, Dr. Egan. Cheryl's case again. We just took a look at where she is, took a look at the treatment planning you had come up with. I wanted to take a look at the anterior teeth. You and I had talked a lot about where to start with her, whether we start with ortho or not. We had taken a look at the PA, and the bone around this tooth isn't too bad. We had talked about potentially orthodontically extruding the tooth to pull some of the bone as a way to increase the vertical width of the bone. At this point in time, the patient hasn't yet necessarily committed to a long-term plan, so you had gone in and replaced these 4 teeth. And one of the interesting things that we wanted to see was whether or not increasing the overjet would allow the jaw to fall forward. So as we can see here, she's pretty close. There's no red dots except for that there, but I have no doubt that her muscles get a sense of the fact that these teeth are trapped up against the upper anterior teeth. Frank Spear calls this pathway wear, whenever the facials of the lower anteriors are worn and or the linguals of the uppers, where these are crowns, and I think they're fairly new, maybe 5 to 7 years. She doesn't necessarily have as much wear up there. Where you see this a lot of older patients that had PFM crowns, where the metal lingual is present on these teeth, and the lower teeth wear down considerably. She probably was heading in that direction. But you came to the rescue, and let's take a look. All right, so these are your PMMA temporaries. Very nice job. And I'm not able to scroll. There we go. I guess I can. All right, so you can see how much space is in there now. Now, if her jaw wants to drift forward because she's quote-unquote entrapped, and we'll have a separate video on really why a patient who has premolars removed is more likely to be trapped or entrapped. But suffice it to say, when teeth are removed, the arch lengths get less, and that arch length decrease has a strong tendency in pushing the mandible backwards, and that's why we see more intracapsular issues, we see more extracapsular issues with the muscles. So it's not too uncommon when you relieve somebody like this that they drift down and forward. So I took a look at your 2 scans, and this is the recent scan with your PMMAs, and I looked at the contact between 3 and 4 and 29 and 30. And if we compare it to her where she started, let me get rid of this so we know which one we're looking at. You know, this looks a little bit more superimposed. This contact sits closer to this one. Whereas if the jaw drifted forward, that space between the 2 would increase. I'm just trying to use 2 fixed reference points to see if there has been some drift. And it's tough to say. Unfortunately, the my iTero software doesn't have the measurement tool like ClinCheck has, but I want to say it's drifted forward a little bit. So I'd be interested to see if we then, sorry, I'm having a little bit of trouble moving this remotely. If we remove these contacts here, where are those contacts coming from? The lateral incisor from your PMMAs and the canine. Actually, that's the canine. No, your PMMAs are fine. So it looks like her canines are still coming into contact, and if that is trapping her forward, it's these contact points which are holding her up. So the next time you see her, I would recommend equilibrating her a little bit to bring her forward. Keeping in mind that equilibrating a patient without a plan is never a good idea, but you and I have talked a lot about this case. She doesn't have TMD symptoms. We're going to be changing her vertical. We're going to be changing, putting her into ortho. I'd feel very confident with you adjusting those, essentially bringing more posterior contacts in. She's got some here, there. So when you remove these, you might not actually notice anything other than these spots changing as her jaw drifts forward. I would have the T-scan ready in case she starts to feel like the bite's getting unraveled. We always run the risk when we're changing bites that the patient's going to lose a very, very comfortable spot in their occlusion. But as somebody who deals with this kind of dentistry, you need to know how to get out of it. And this would be a great patient to get lost so that you could figure your way out. It's always a good way to learn. So that's where I'm at. I'd be really curious to see how her jaw might drift down and forward and get more class 1. You and I did look at her condyle inside of the disc space. She definitely was in the distal part of the compartment, but that doesn't necessarily mean that that's a problem, and it also doesn't mean that's not her normal. But it is something to suggest that it's possible that her jaw is distalized. Now, if her condyle was resting up against the anterior superior part of the compartment, up against the eminentia, then we know that this is probably her centric relation, or very close to it. So we're looking for clues to paint the story. And let's just assume that this is her final position. How do we proceed forward? Well, is it possible to intrude these teeth orthodontically? Yes, but probably not. With brackets, 2.5 years of treatment, and maybe some Wilcodonics or wrap phenomenon treatment where we induce some inflammation surgically to get these teeth to move better, I don't see us leveling this curve of speed too much. So, are we going to do Invisalign on this case? Well, we're not going to use Invisalign to fix it. We might use Invisalign to set us up for a better prosthetic outcome. So, where the patient wants an aesthetic improvement, she's not interested in surgery, because this could be a surgery case if we decided to. She wants an improved occlusion. She wants a broader smile, so uprighting these posterior teeth would be something that she'd be interested in. And she has a class 2 setup. I think we can use Invisalign to achieve a few things. The first thing, arch width. Again, my iTero scan doesn't allow us to measure, but I bet her inner arch width is insufficient. If we go back to her photos, we always want to look at the tongue, see how the tongue is doing in relation to the posterior teeth. And that doesn't look too bad. On this photo, when the tongue is squished, you can see the tongue being squeezed through the midsection here. We always want to account for any potential sleep issues. Sleep apnea comes from obstruction. Obstruction comes from the tongue. What is the tongue bordered by? It's bordered by the teeth. So if the teeth are narrow, the tongue gets squished, gets pushed back into the airway, and can increase the chances of sleep apnea, upper airway resistance syndrome, and a host of other related conditions. The point is, the tongue is potentially too small. But I'm not seeing that here. More often than not, we do see that with premolar extraction cases, because of the teeth being removed, decreases the arch length. So I don't think we need to use Invisalign for that. We also don't need to use a palate expander, adult palate expander. I think what we need to do is upright the teeth. So uprighting teeth does a couple things. It's more aesthetic. When the patient smiles and more teeth show in the buccal corridor, it's a more aesthetic and pleasing smile. The forces of occlusion are directed down the long axis of the teeth when they're upright. Teeth are not supposed to be tilted like this. I will do a separate video on why that happens. It's actually a pretty interesting phenomenon that tends to only occur in first world nations, industrialized nations like America. You wouldn't see something like this in Indonesian countries where the pygmies will eat natural foods and they use their muscles. But again, well, separate video for that. The point is that we want to upright these teeth. Invisalign does a very good job of uprighting teeth. What will uprighting teeth do that's really to our benefit? Increasing the deep bite, or decreasing the deep bite, and increasing the vertical dimension. Plus, we can intrude these teeth somewhat. We can also align them and bring them forward. you've already created some space by changing out the crowns in the anterior. How long do I think this will take? I think 9 months. Again, we're not looking for perfection. We could do this restoratively, but I think if we do this, we could save the patient some money by not having to crown all of the teeth to open her bite. I think we could get away with 4 crowns on the upper. You know, we'll have to talk more about number 10, whether or not that tooth would need to come out and implant or bridge put in, but let's just assume for now that it's going to stay. Root canal and crown these 2 teeth most likely, or remove and do implants. But the rest of the upper teeth look like they're in good condition. How does the upper occlusal plane look? Looks good. Her incisal edge is a little bit shorter than her posterior teeth. Is that right? Well, let's take a look at her photos. You know, she looks like somebody who has a collapsed vertical. You can see her lips. That's not repose, but when her lips are touching, they have a frowning appearance. Not uncommon with a class 2 case with posterior teeth tilting like that. So let's look at this photo. I think 8 and 9 can be a little bit longer. Unfortunately, when this photo was taken, Chantel was not taking repose photos. Oh, I guess she was. All right. There we go. Female, middle-aged female at rest. That looks pretty good. I wouldn't go any longer than that. That's where she started, and I did just realize that we have photos of her after your provisionals were in. And now we can't see the provisionals. It's very possible her lip is at more rest, but I would keep them there. I don't like when posterior teeth are longer than anterior teeth, but it really doesn't look that bad here. I would probably enamelplasty the posterior teeth, and if anything, lengthen them maybe 0.5 millimeters. All right. That would be it for the upper. The lower, canine to canine, they look pretty good. I would restore the anterior teeth with composite and then crown her posterior teeth at the vertical of dimension that we choose. So composite in the anterior, crowns in the posterior, at a proper vertical dimension. Give her some anterior protrusion here. Yeah, her tongue does look fairly squished, but as we upright these teeth with Invisalign, that's going to improve. All right, so that's it for Cheryl. I would run this phase plan by her and see what she thinks. And just for those reviewing this, this was your phase plan. I'll quickly go through. You can hit pause on the video if you want. So that's page 1, page 2, page 3, page 4, and page 5. This plan that you did was just over a year ago, and we've changed some things here. So I would take the conversation we just had and put it together with a new phase plan, present it to the patient, and when you're ready to get started, we'll get her in for Invisalign impressions. All right? Enjoy.